Hi, everyone. I'm Kristen Darcy, and I'm a fertility coach.
And I'm Sarah Knabb. I'm the co-founder of Track, the editor of Don't Cook Your Balls, and a men's sexual and reproductive health coach.
Today, we're continuing with the topic of cancer and fertility. And I'm so honored to have Leslie with us. And Sarah's going to let you know all about Leslie and what we'll be talking about. Oh, God bless you.
I'm sorry. I'll have to explain that I have a horrible cold. So my voice and my coughing.
Oh, but thank you for being here, being not feeling up to snuff. We so appreciate it.
I'm super excited that this year we're dedicating a whole day to the topic of cancer. This has been something that's come up a couple of times throughout the summit, but really taking the time to explore it in some depth. And we've talked to Tamara and her husband about their journey through cancer. And today, I'm really happy to bring Dr. Leslie Schover, who is a clinical psychologist and has been specializing in cancer-related problems for sexuality and fertility for the last 35 years. So she was a faculty at the MD Anderson Cancer Center for a large portion of that, and has really done some pioneering work to help bring issues of sexuality, intimacy, and fertility to the forefront of the field in cancer. And that's just really a great work and a great service. As we talked about before, that a lot of cancer changes a lot in people's lives, and this is one area that hasn't gotten as much attention. So maybe you could tell us how did you get into this as a profession or as a field of specialty?
Well, sure. Well, when I was pretty early in my career, I was working in Houston and got a job offer to come to MD Anderson, and I didn't know anything about cancer. I had to educate myself kind of from the ground up because, you know, in psychology graduate school, now they have health psychology programs, but that had barely started when I got my PhD. So I had to learn all about, you know, the different types of cancer and treatments and how they affected. At that point, I was really focusing on people's sex lives, and I was in the urology department. So, you know, I got a lot of exposure to bladder and testicular and renal cell cancer and prostate cancer, all you know, ones where reproduction can be very important. And I stayed at MD Anderson for about 5 years, and then I left for a job at the Cleveland Clinic. And there, for a lot of the years I was there, part of my job was to be the psychologist for their infertility program. And so I continued my interest in cancer, and I realized that, you know, very little work had been done on how young cancer survivors felt about having children. And some people just assumed maybe most of them didn't want children after having cancer. So we did one of the first surveys of young survivors and found that, especially of those who had not had children when they were diagnosed with cancer, that about 3/4 of them did want children in the future. And soon after that, I ended up going back to MD Anderson for a number of years, and we did both research and clinical work trying to help people get educated about what their options were to preserve their fertility as men or women when they were diagnosed with cancer, and to understand the impact of infertility due to cancer treatment on their quality of life. And part of that research was funded with some grants from the National Cancer Institute that were small business grants. And those are kind of unusual grants because they come with the expectation that you're going to create a new program, an assessment or a program to help people cope, and that you're going to actually turn that into a small business. So in the last 3 years, that's essentially what we've done. I started a company called Will to Love. I'm sorry, this cold, called Will to Love. So it's WILL, the number 2, and then the word love.com is our website. And we offer online help for cancer-related problems with either sexuality or fertility to men and women. So that's kind of part of my journey and how I got here. And the thing that motivated me was that despite the fact that there are practice guidelines that say that oncologists should talk to patients about sexuality and fertility, it often doesn't happen. And then, some of these things are time sensitive. If they don't get brought up early in treatment planning, it may be too late to preserve fertility, for example, like to bank sperm for men. And also, it's just very hit and miss. Some oncologists are wonderful at talking to everybody, and some try to avoid it as much as possible. So when the internet came along and people started using it for health information, it seemed a great opportunity to, be able to go directly to patients and empower them to understand how cancer could damage fertility and what their options were for becoming a parent after cancer.
That is so important. I was actually just in a walk in my neighborhood and ran into a woman in our neighborhood, and she was mentioning that her son, who's 30, was diagnosed with prostate cancer. And being who I am, I jumped in. I don't know this woman very well, and I said, well, has he made a decision about preservation? And she said, well, this is his second round of cancer treatment. And as a matter of fact, they didn't mention it to him till right before his treatment. And he didn't preserve.
Oh, that's a shame.
Isn't it? And so when you say that some conversations about preservation or, sexuality, they happen after too late. And so that's why Sarah and I were so, strong about having this topic about, empowering a man or empowering a woman to take a stance to preserve their fertility. And of course, they're probably overwhelmed and only trying to think at the moment, of the overall body health of just moving through the cancer, that, maybe they make a decision at this moment that's not going to reflect how it is when they're on the other side of treatment. So how have you found that conversation, or what would you say to empower a patient who just received a diagnosis?
Well, I think it's important as early as possible in treatment planning to ask if your cancer treatment is likely to damage fertility. And if the answer is yes, then, to find out if you can get a referral to talk to a specialist about what your options are. And for men, it's a lot easier in some ways than for women, because banking sperm has been around for a long time and is a very well proven treatment. And, to bank several samples and store them for a few years, maybe it's not cheap, but it maybe costs $2,000 or $3,000. The problem for women is often that they need to go through a cycle of IVF or ovarian stimulation, and that can cost up to $10,000. And here are young people being hit with all the potential medical bills of cancer treatment, and they have to worry about this as well. And there are a number of organizations that offer some financial help for fertility preservation for men and women, but you also still have to apply and fill out forms, and, at a very stressful time. Plus, we have a cultural kind of value, which is to some extent a myth, that once you have cancer, you'd better start treatment tomorrow. And that if you delay treatment even by a couple of weeks, you could be jeopardizing your life. And there are very few cancers for which that's true, like acute leukemia is a good example, where it's a life-threatening emergency in many cases. But for most other cancers, delaying treatment for even 2 to 4 weeks, there's no evidence that that's going to change the efficiency of or ability of treatment to work for you. And that's usually enough time to find out, how to preserve fertility and decide if you want to do it. And there's certainly a lot of research that suggests that people who have had the chance to have a consult with even, like an advanced practice nurse or a reproductive endocrinologist to discuss their options feel a lot more comfortable than those that were kind of rushed through things and never had a chance to even consider it, even though it's a relatively small percent of men and women who decide to go ahead and bank sperm or eggs or embryos.
How prevalent is that thought among the oncology community that it's okay to delay? Because you're right, it is a very pervasive feeling that like you get a diagnosis of cancer and it's time to go, like let's treat it right now. Is that common in the medical, or is that just among patients and the consumer market?
Unfortunately, it's still fairly common among oncologists as well, especially out in the community, people who might not, be practicing in a large major cancer center where they get updated a lot on, latest thinking about things. So, that can be an issue. And I think sometimes there's just the fear of, the fear of malpractice suits, the fear of delaying, the inconvenience of delaying treatment to do another consult instead of going straight ahead. So all these things can, contribute. The other thing is we did a survey of oncologists back in the early 2000s at the same time that we surveyed patients about their values. And we discovered that a lot of oncologists were cherry picking the patients that they spoke to about fertility. So if the patient was single, they might be maybe more likely to speak to them, more likely if the patient was childless. And if the patient had even one child, they would maybe skip the talk about fertility without asking if they were planning to have more children. Or if the patient was of lower income or not insured, they would just assume that there was no way they could pay for fertility preservation, so they shouldn't bring it up. Or if a patient was HIV positive, or if a patient was gay, all these kinds of things. And whenever I talk to oncologists and oncology staff, I point out that it's not our role to be paternalistic and choose, who should get this information or not. Everybody should get this information. And that's now also a guideline from the American Society of Clinical Oncology.
That's so interesting, isn't it, Sarah? I could see your wheels turning, Sarah. I could see you thinking, like that is just so important to talk about. It's so important to, empower that, I talk about infertility has no boundaries. It doesn't matter what religion or race or your economic status. Infertility can affect anyone. And so what you're saying mimics that cancer affects everyone. Everyone either knows someone or someone in your family. And to have that, and I don't want to use the word bias, but it's a self-bias of who you should share this information with. I have to sit with, right, Sarah?
I think it's human nature. Like it's naturally easy to think about these conversations for certain kinds of people, right? And it's harder to go, well, I don't even know how to bring this up because I don't know if it's going to be a sensitive topipic. And I don't know, I feel like there's a human emotional factor. Right? So it makes sense to me that bias exists, and that it's probably unintentional.
Yes.
But it's just a thing, right? It's just human nature. And I'm really glad of the work that you've been doing, because I feel like, people are in such a state, everybody's in such a state because we have such a goal of preserving life at all costs. We are going to cure things. And fertility is one of those things that doesn't fall into the bucket of life or death, but it is the essential human. It's an essential human thing. Sexuality, intimacy, right? So living and having this quality of life of the life you want to live they go hand in hand, you know, so it's very important to bring these conversations up, but hard.
Yeah, and also, you know, most doctors and nurses get very little training in how to talk comfortably to patients about emotional issues in general, and particularly, you know, fertility or sexuality that are so personal. And, you know, it may be even more difficult if the doctor and patient are very different in age or ethnicity or religious background or all of those things. So we started last summer a kind of a little public health campaign that we call Bring It Up. So it has a website, which is just bringitupsexandcancer.com without any periods until the .com. And we have 3-step action plans for patients and for professionals. And the patient plan is, you know, when you have a question about fertility, you should, when you make your appointment or at the beginning of appointment, wherever you have a chance, mention that you have a special question that you want to discuss. So please leave some time, you know, in the appointment to discuss it. And then have a specific question that you've kind of put together so it's easy for you to get it out. Like, you know, I'm concerned about the different options I have for cancer treatment and how each of them might affect my ability to have kids in the future. And when you ask your question, make sure you don't leave that appointment without some kind of next step, a referral to see someone or an answer, something that makes you feel like you're on the road to, you know, getting your needs met. And for professionals, the 3-step action plan is, we ask them to ask one question in every appointment about, you know, cancer often causes problems in people's sex lives and fertility. Do you have any concerns? And if the patient says yes, then hopefully they should have some people on their staff who have the time and training to sit down with the patient and really explore. I'm so sorry.
No, that's fine. We're sorry you're not feeling well.
Or, you know, what the patient's needs are, and then to have a referral network of specialists that they can send the patient to.
That's so powerful. You're educating both parties at the same time, and you're providing a 1, 2, 3 for the patient to give them permission to ask this in a way that's structured for them. So that's so powerful, empowering.
You know, and I think this actually extends beyond cancer. I'm just, you know, as I'm listening to you, I'm thinking about my own personal experience. So last summer, I went through a diagnosis process for a autoimmune disorder, and fortunately, I was like determined that I didn't need to go through treatment, but the treatment that got put on the table was actually a chemotherapy. And the drug in question, I knew because of the field that I'm in that it was a gonadotropin. And so no one even thought, no one, like, I mean, I have 4 kids, so like, but still, you know, and it wasn't cancer, so it doesn't necessarily ring the bell to a patient like you're getting treatment for an autoimmune disorder. It could also involve these heavier drugs. So these drugs are used beyond just cancer. And so if you're going through a serious health condition where you have a major surgery in your groin region, in your genital region, or strong medications, it's a worthwhile question to bring up. You know, even some of the testing, the CAT scans and the other things, right? It's just worth mentioning and understanding so you can make an informed medical decision.
You know, the other thing that I think we often ignore a little bit because we focus so much on fertility preservation is that most people don't, you know, freeze sperm or eggs. And so after cancer, if they do want to become parents, they have a whole series of decisions that they have to make. I mean, one thing is finding out, am I still fertile? Is it possible I could conceive naturally? Or is there some infertility treatment that could help me? But
yeah, I just wanted to bring that up because, so, you know, these questions we're working on that end to try to bring awareness, but there's still a lot of times where people don't have this come up, or the cancer is acute and they really need to go right into treatment, or lots of things. And so now they end up on the other side and grateful to have made it through everything, but now wanting to rebuild their lives. What are some of your suggestions for helping someone kind of regain their sexuality, their fertility, their intimacy after they're kind of been through the recovery process?
Well, you know, it takes some work. And I think people often hope that everything's going to happen naturally and they don't have to do anything special. But I think certainly when it comes to fertility, you know, for men, since we're focusing a lot on men, you know, TRAC obviously has the system to keep some track of your sperm count. And, you know, some men just assume they're infertile and then they have an unintentional pregnancy because they didn't realize that, you know, in fact, they're not infertile and they do have viable sperm. So that's one issue. And another issue is if a couple's considering having children and, you know, they're wondering, you know, can they conceive naturally and how long should they try before seeing a specialist? You know, after cancer, people usually say, don't wait a whole year like they often tell young couples, but maybe wait 6 months and then go see, you know, for a man, it might be a urologist or andrologist to get some semen analyses and also check out the female partner's fertility because she could also have an unsuspected problem. So that's one issue, but there are also the issues of other pathways to parenthood, like adoption or donor insemination or donor embryos, or for women, donor eggs. And those are very tough decisions to make. A lot of times the options are very expensive other than adoption through public agencies, which is, you know, a fairly minority of adoptions in the United States. And for international adoption, a lot of countries will not allow couples to adopt if one of them has a history of cancer, and the few that do require often a letter from the oncologist saying they're 5 years out from their diagnosis and have, you know, the expectation of a normal lifespan. So there are some barriers to adoption, even among domestic agencies who often don't like to talk about what their criteria are, or when mothers pick couples to adopt a child. Although many people who are cancer survivors do adopt successfully, but they have some extra hoops to jump over in a process that's already difficult. And in, you know, getting used to the idea of third-party parenting, where you might have a donor sperm or donor egg or donor embryo or a gestational carrier or surrogate who helps, you know, those are all wonderful options, but they also take some psychological self-examination and acceptance and making sure that both people in a couple, if it's a couple, you know, feel equally comfortable with those options, and making sure that you do things through very legitimate agencies that help so that everybody in the process gets a chance to have some counseling and support.
That's fabulous. Thank you for outlining all of those options, and also being really honest about some of the challenges, because I think people like to, you know, say, well, there's lots of options to become a parent. You can just adopt, or you can just do this, or, you know, it's like, it's there, so you could just make some choices. But in fact, those choices are not always, you know, each of our roads are different. Each of our abilities to choose one path or another are can be limited. And so I just really appreciate you.
Yeah, that was
putting it out there.
Yeah, that was wonderful how you just explained that, because for me, you know, Sarah and I have come together to do this, but I'm the emotional component of infertility, and listening to you, I just, you know, want to provide hope for people we know if you have experienced a cancer diagnosis and you're on the other side and you're trying to, consider how you create your family, there is options, and it can feel overwhelming. But once you build that team, once you have this team around you that can help you navigate it, just the same as if how you navigated your cancer diagnosis, you can create your family. But you said that also eloquently about all the choices, that it can make your eyes spin. Like, what do you do first, right?
Well, and not only that, but, there is all the emotional aftermath of having cancer, the fear of recurrence, and the worry about, will I live long enough to see my children grow up and be able to be there for them for all the milestones, or will I be, somewhat disabled or ill over those years? And those are all, valid considerations for people. And I also always want to put in that not everybody has to be a parent, and you can be a very happy person and have a very fulfilled life without being a parent. It's just a matter of your individual, choices. But, one thing I see people do sometimes, and I see this more with women than men, or maybe women are more overt about it, but, women so much are taught that we grow up and our major role in life is going to be a mom. And when women are infertile, they often have so much grief and anger. And, it seems like everywhere they look, there are pregnant women and babies in carriages, and they're invited to their friends' baby showers, and at holidays, their sisters or cousins have little children that everybody's making a big fuss over, and it makes life just a misery for them. And some women, and I'm sure this happens with some men too, it's just less obvious, they tend to withdraw from any situation where there are children. And I think that's kind of sad. So I also tend to try to talk about other ways to interact with children other than being a parent, like, being a mentor, being a teacher's aide, volunteering, all the things that you can do to avoid that rigid feeling that if you see a child, the only thing you can feel is misery. So
yeah, I was one of those women, and I lived that. I abandoned my Target cart in the middle of Target because I was, surrounded by pregnant women and women with babies. And I think it's part of that grief process. And I'm glad you brought that up, because what I have found too for men, it's the same mirroring of the feelings, but processing and bringing your awareness to those feelings, those denser feelings, the grief, the sadness, the betrayal that you go through. But it's processing it in a different way. And so I'm so glad that you brought that up, because we, Sarah and I talk about men emotional component of male infertility. And so compound that with a cancer diagnosis, that to me means you need to have double the team to help you get through. And your resources on your website is so thank you.
We also have like the triple whammy of the traditional male role, which is, provide for your family, be a sexual, partner that gives pleasure, and give women children, and cancer threatens all three of those.
I never thought of that. Yeah.
So
we're so sorry. You're so sick, and it's so great to do this. You're not feeling up to snuff. We so appreciate that.
So I like one kind of last question of wrapping it up. So if you're a guy and you've been through cancer, and you're on the other side, and you're starting to rebuild your life, and you're starting to try to put all these pieces, and it's like just a big pile of pieces now. You have your health, and you have your profession, your occupation, you have your partner, or you're considering a partner, or wherever, and you're trying to think about, do I want to become a parent? Should I, when should I start to be the process of trying? If I did, what what tools or advice do you give to people who are trying to work through sorting all that stuff out?
Well, I think there are some things that should take priority, like feeling like you're at a reasonably good place in your life with your career and your relationship before you start out having children. Unfortunately, life isn't always that neat and easy, but that's certainly something that's going to make going through the whole stress of trying to have a child after cancer a lot easier if you feel a sense of stability in other areas of your life. There are also some medical concerns, although, big studies like in Scandinavia, they have these big databases of everyone who was born in a country and everyone who's had cancer, and they're able to cross-check them and look at, the health of children born to cancer survivors. And when the father is the one who's had cancer, there are very, very few pieces of evidence that there are increased rates of birth defects or cancer among children of cancer survivors, unless they have a gene in the family that's mutated that, gives them a very high risk of a particular kind of cancer, and that's rare. But there is a little bit of evidence that, especially in the first 6 months after chemotherapy or radiation to the pelvis, there might be a slight increase in birth defects of children conceived during that time. So it's good to wait at least 6 months after cancer treatment is finished if you're having those kind of treatments. And the safest recommendation is to wait 24 months. Sometimes those recommendations are given more with the idea that most cancer recurrences happen in the first 2 years. So if you get through 2 years without the cancer coming back, that's a good sign. So that's another reason maybe to wait a little bit. Men have less of an issue than women with our biological clocks. And a lot of women, since cancer is a disease of aging, when women get diagnosed with cancer and they're still in their childbearing years, they're often like in their early or mid 30s. And that's where waiting gets to be difficult, because the more years you wait, the less likely it may be that you'll have an easier time getting pregnant. Men luckily don't have so much of that biological clock ticking.
Exactly.
That's great advice. One last one is, I know that, so in our last conversation, they said, well, once you start these chemo treatments, you can't have unprotected sex because it's not safe. So when is that just related to the family building, or is that exposing your partner to radioactive stuff, like bad, heavy drugs?
Well, number one, if we talk about chemotherapy, there may be some chemotherapy drugs that can be present in semen or vaginal fluid. They're probably present in such small concentrations that it's really unlikely to hurt the partner. But because of liability and because there's so little research on this, a lot of oncologists will tell couples, use some kind of barrier contraception, like, preferably a condom or a female condom for, several days, or, depending on the chemotherapy drug, after your chemotherapy treatments, which are usually spaced out, with several weeks in between. But, there's very little evidence for that fear. But I would be more worried when the man is having chemotherapy and if his partner might be pregnant already. That's when I would really worry that those small concentrations of chemotherapy drugs might somehow, get in the woman's circulation and harm the fetus. And so, that's a situation where I think it's very important to use barrier contraception. But I think, the main concern there is probably, not to start a pregnancy while one partner is undergoing chemotherapy. As far as radiation goes, only a few types of radiation stay in the body, like when you implant radioactive seeds in the prostate. There is a small period of time, usually several days, when you're not supposed to you know, try to have intercourse or get close to your partner. And again, you might want to take more precautions if there's any possibility that your partner might be pregnant. But most radiation from an external machine just passes through the body, so it can't harm a partner. And even with those seeds, after, you know, a couple of weeks at the most, you know, their power to, you know, affect another person is gone. So
thank you for breaking that down. I mean, I think these are the kinds of things where misconceptions, because the conversations are so brief and you're afraid to bring it up, then, you know, people just kind of live with these well, okay, does that mean that I'm like, my semen is permanently like radioactive or something and I shouldn't be having any more sex? Or like, you know, and then you just don't want to bring it up because it's awkward. Like I shouldn't really want to talk about this, but again, it's good to hear, and it's good to have such frank, open conversation. And I think it's a reminder that, you know, you should be able to talk to your oncologist about any of this stuff and really make sure you get a clear answer so you understand what your treatment is and what its impact is longer term.
This has been so informative and so necessary. And Leslie, we so appreciate you being here, and you're not feeling well. And
I'm just sorry, it might make me hard to understand or listen to, but you know, I figured, you know, time is of the essence, and this is when you're doing it. So I'm glad I could participate.
That's right. And so if you want to reach out and speak with you direct, if someone wants to reach out to you, they should visit willtolove.com. And is there a way, all this information will be underneath this video, but is there a specific place that you would like people to reach out to you if they wanted to?
Well, we have an email address that's info@willtolove.com, and they certainly could email me there.
Wonderful.
I should mention, too, that a lot of our specific information in our self-help programs for men and women are password protected. And so we've been doing a study with the American Cancer Society where they were available for free to study participants, but we just closed the study to new patient entry. So in the future, we are trying to get contracts with hospitals, and the patients of those hospitals will be able to access those materials, or will have paid subscriptions, which fewer people want to really do. But there is also a big resource section that's free on our website, and a blog section with a lot of different topics, and even some webinars that we recorded. So there is a lot of free information on the website too.
Thank you so much. Thank you.
Yeah, and I'd love to plug that. Like if you've been through cancer and you're just trying to put your pieces back together, or you just got diagnosed with cancer, or someone you love have been diagnosed with cancer and you just want to learn more, Will to Love is an amazing resource. Everything and anything related to fertility preservation, building your family after, sexual questions and concerns, intimacy, how to restore intimacy, what to do if your sexual function is gone. I had an amazing time poking through this website and learning some things, and it's just a really invaluable resource for things that aren't really out there in a lot of places. So I just really commend this great work that you're doing in building this resource for people who don't have a lot of places to turn.
Well, thank you very much. And I didn't pay Sarah to say that.
And there's no money exchanged during this interview. Well, thank you so much. I so appreciate it. Nice meeting you.
Nice meeting you both.
Bye. Bye, Sarah.